So, welcome everyone to this ultrasound hands-on session. Just want to, before we start today, the first topic is ultrasound of the right upper quadrant. But before we move further, have any one of you ever done ultrasound, held an ultrasound probe, or done anything? Okay, and in what specialty or in what regard? So,
I do anesthesia
okay,
and management.
okay, perfect. So you do more MSK.
Yeah, MSK, nerves.
Okay.
I've done fast exams for safety.
Okay, perfect. That's great.
Internal medicine, so
Okay.
just
Fast and focused bedside. Okay, so that makes my topic much easier because if you've held an ultrasound probe before, you know the orientation, you know the general layout of the body. We can slide. So ultrasound, the right upper quadrant is the most common test ordered that we get in our ultrasound department. The organs that we scan are the liver, gallbladder, pancreas, and the right kidney. So any concern a primary care provider or a specialty provider has, whether they're concerned about liver pathology, gallbladder pathology, pancreatic pathology, anything with the right kidney, the study to order would be a right upper quadrant ultrasound, most commonly examined, ordered study. Today, our focus will be mostly on the gallbladder. That is our most common order we get via the emergency room, rule out cholecystitis, most common cause of abdominal pain. The first diagnosis that jump to is cholecystitis. That's okay. So the scanning protocol varies from department to department. Every hospital, every radiology department has their own protocol. Slide. Just a basic overview, every organ we scan on ultrasound is scanned in two planes. So a longitudinal or a sagittal plane and a transverse plane. So this is just showing a linear probe, and each ultrasound probe has a marking on it, which you can see. The marking for sagittal has to be cephalad. The probe has to angle straight. For transverse imaging, it has to point to the right. And this is the patient's right, not your right. So when you're scanning facing the patient, the probe should face the patient's right. So basic scanning, transverse pancreas probe is placed in the epigastrium. The image on the top shows a transverse placement of the probe. The image on the bottom shows a sagittal placement of the probe. This is a transverse image of the pancreas. I can point out the head, body, pancreatic tail, portal confluence, splenic vein, our landmarks, aorta, SMA, and over here you'll see the GD and CBD. So these are the classic. This is a beautiful image of the pancreas, which I got my students to volunteer to scan, and I'm like, on the bed, I'm taking pictures. So, when you see that no pancreatic masses, no dilated CBD here, you'll sometimes see a huge CBD in the posterior part of the pancreas there. The next slide shows the pancreas with color Doppler. So, all of you, I'm sure, have studied physics at some point in your life if you're in medical school or physicians. Doppler just shows direction of flow. So it's basically the red and blue means whether blood is flowing towards our transducer or away from the transducer. If we place our probe here on the patient's body, blood is going this way and this way, so red and blue. It doesn't mean that anything major is happening or there's any pathology there. Next slide. Liver, the largest organ to scan in the right upper quadrant, cannot be missed. Wherever you put the probe, you will always see the liver. The protocol would be to scan it end to end, white lobe sagittally, transversely superior to inferior. I have a measurement of the liver up. Most places, the protocol is to measure the liver in the mid-clavicular line, deep inspiration, and where you see the focal bifurcation. So there's a focal bifurcation there. Tip of the liver to the diaphragm, 14.8, 15 centimeter liver. And the next picture would be what we will focus on in a little bit. This is the main portal vein, and you can see part of the liver, main portal vein entering CBD, hepatic artery right there in the cross section. And then I have a color and Doppler image of the same color picture of the portal vein. And then, so this portal vein, if you remember the pancreas image, was blue on the top because it was diving down and then entering the liver. Now we're coming intercostally. Blood is flowing towards our transducer, so the vein appears red. And then the next picture would be a spectral waveform. Okay, move on. Any questions so far? Okay. So the star of our show, the gallbladder. The gallbladder is a pouch that is on the underside of the liver. So the basic area to scan would be subcostal or an intercostal approach. But of course, depending on every patient's body habitus and how big or small their gallbladder is, you could utilize other windows to get a better image. This is a sagittal image of the gallbladder. Next image would be the transverse image of the gallbladder right there. And we have the probe basically in the transverse position. You can see the green dot that faces the patient's right. So when this image, when the ultrasound image is projected on the screen, patient's right, patient's left. This is an image of the common bile duct. Again, we have our landmarks. We can see the flow in the main portal vein. We can see the flow in the hepatic artery, and the CBD, the common bile duct, is anechoic. It has no flow, blood flow. It's nice and black because there should not be any vascularity, or the Doppler shouldn't pick up any flow from the bile. Next slide now. Again, a measurement of the CBD measured inner wall, inner to inner. Any questions at any point, please ask as in regards to measurements or patient positioning. So our next slide will be just maybe an image of the right kidney, because we also scan that is included as part of the right upper quadrant protocol. But I know that we have a urologist who will go into renal ultrasound in detail, so we'll just ignore the kidney for today for this part of the presentation. But this image is an excellent image to compare the epigenicity of the liver to the kidney, which helps show whether there is either liver disease or kidney disease. Mostly the term that there should be the same grayscale imaging, which is called isoechoic. So the gray shade in the liver and the gray shade in the renal cortex. Cortex, and then the central sinus echoes. So these should be similar in grayscale imaging. And that basically concludes my brief presentation for today. If you have any questions, I can answer that. And yes.
What are the new innovations that are coming in the ultrasound field nowadays?
New innovation as far as technology or as far as scanning?
As technology and scanning, how new things that you can do now that you couldn't do, let's say, 4 or 5 years ago.
MSK is very big. Nowadays, we couldn't really do that before. Pediatric imaging is coming up a lot. We are seeing a very high rise, especially where I work in my hospital, like appendicitis, a lot of them on any pediatric patient, intussusception, and things like pyloric stenosis, and those are stat exams that are ordered on babies. But in general, on the emergency room, we're seeing an increase in those kinds of studies. And MSK studies are on the rise because physicians are getting more and more comfortable with seeing grayscale anatomy on ultrasound versus MRI, which has its own, limitations and drawbacks. The technology has changed. The resolution has become so much better with the machine quality, and every machine, we have a GE machine today, but GE, Siemens, or Toshiba, they all have different bells and whistles that were not there a few years ago. So with improved resolution, improved color flow, improved Doppler. The technology itself has changed as far as the screen layout, the ergonomics of the machine, and it just helps the scan go faster and quicker. Before we had to type stuff, now we have what is it called? Like a template. You just pick and choose. We have auto scan where the whole protocol is scanned in, and all you do is just push a button and everything just comes up. This is the next image. This is the next image. Like, you don't even have to think about it.
Should we start scanning?
We can start scanning.
Let's do that.
One little question.
Yes.
Do you have any insights into the more affordable ones like butterfly?
I do not. I haven't really used them. I work in an ultrasound. I work in radiology, so.
My butterfly.
You have your butterfly, so maybe you can demonstrate that and help us with that would be great.
You like it?
So let's send a thank you for helping us with this. So we'll demonstrate and then we'll get everyone hands on. If Tamara पास भी है, so you can, if you want to talk, then we can get two things going at once.
Yeah.
I just need you to hold your shirt up.
I'll be fine. I think
Just, I think it's good.
I'm sorry, it's not a very comfortable table.
So I mean, I think if you guys want to come up a little bit so that you can come on maybe this side or that side actually, in a way that you can actually see Tasneem scanning to see how she's placing the probe, where she's placing the probe,
And then,
and what kind of image is being generated from it.
and then we do have this projected on the screen also, so hopefully it will help.
Hopefully.
Lamana
Oh,
Hussain.
here. Oh, okay. So patient positioning makes a lot of difference. It helps ease the image acquisition. So for a right upper quadrant, I would have you, of course, pull your shirt up, please, straighten your legs out, and it's not very comfortable for me to use when you take it to it. And then your shirt pulled up. Okay, my hands are extremely cold, I'm so sorry, and the chair is very cold too. Right arm up over your head. So what the right arm up does, it stretches out the ribs.
Any
and
permissions here?
even the torso, and makes it very, very easy to get good pictures. All right, so we'll start with the Panc. So this is my ultrasound probe. This is a curved probe for all of you who use ultrasound. This is the notch here which says patient right. So basically, we're taking a 3D body and putting it on a 2D screen. So how that works, when we are in the transverse plane, this part, the top of the screen here, is anterior. The deeper you go is posterior, right, and left. When you are in the sagittal plane, the notch faces the patient's head. Again, anterior would be on the top of the screen, posterior would be the bottom of the screen. And instead of right and left, now we have lateral and medial. So just depending on the plane, how you're traversing the, or, scanning. All right, hold your, ready? Sorry. So we'll start with the pancreas, quick, a little blob of jelly, the epigastrium, and then we have the gain here. Igor, you'll help me with the settings here. So we can see, let's pull up the cursor here. So, Igor,
Can you help with the settings on that?
so here is the pancreas. We see the landmarks here, aorta, SMA, Panc here, splenic vein going into the portal confluence, IVC on the side here. Okay, so Hussain, I'll have you push your belly out, make a fat belly, blow it out, and that really, okay, you may relax, he's drinking. Okay. Thank you. Let's turn the beam down a little bit. Let's have you make a fat belly again. And then you come up and in there. So that sort of pushes the pancreas out. My image on the screen looks much better than up there. Freeze, relax, breathe. So let's clear this. Can you scroll back here?
This is transverse?
This is a transverse pancreas. Okay. So if I bring my cursor up, you'll see the pancreas going from the head of the pancreas, body of the pancreas, the tail will go down here. I will unfreeze and then we'll get a better tail image. Right there, almost there. So this is the tail, pancreatic tail there. Okay. This whole thing is the pancreas, yes. Mhm. We can do that, or I can quick go over to the gallbladder and then we can practice pancreas and gallbladder at the same time. We can do that too. So I'm turning my probe. This was transverse pancreas right there. It's beautiful.
Exam to identify like pancreatic lesions.
Pancreatic mass, yes, but they're very hard to see because they're like, microadenoma, so very visible. But mostly for distal ductal dilatation and choledochoric paroxysm. So turning the probe candidly, facing that. So on this image here, you can see the head of the Panc there. Here. This is the pancreas head there. And I'm slowly going to go right to left sagittally. Okay. So still pancreas over here. And then over here we have the tail of the pancreas. This is a difficult image for people to visualize. Here's the person. This is the tail. Because not of the texture and the gas there too. And you have to realize that the pancreas is at an angle, the tail is higher than the head. So when it sort of curves around, when you're sag, the tail appears different than one would expect it to be seen. It appears more vertical because of the way it's coming down. So on this image,
What side is superior?
no, superior is here. Yes, yes, you need more separate. Yes, okay. Towards the feet. Yes.
Top of the skin is
Is-
No, the
No,
top
the
is the
skin
skin is the
is
the skin is the top.
top of the skin is
Anterior? Yes. Yeah, so this is superior, that's cephalad, this is going towards the feet, just distal aorta body.
Head, feet, skin,
Back. And then
But that's only with the sagittal. right?
both.
For both. For transverse too.
Transverse would be right to left.
Right.
I'm getting gel on your words. So the only difference is the anterior and posterior is still the same because the sine wave is going from here to the bottom. So the skin and the back is the same, but now our orientation would be right and left. So towards, so correct. So this is the right, the head of the Panc, and the liver. If I slide over, we should see the liver there. Again, midline, and if I slide over to the left, eventually coming over, we'll see the spleen up here. But the spleen is quite high. It has to be. We'll have to scan that. So moving on to the gallbladder. So Hussain Bhai was given specific instructions to have double meal and make sure he ate really well for the test. Yes, so someone miscommunicated. Typically, we need the patient to be fasting a minimum of 4 hours. So this is a classic example of what we would get
Right in the
through the
emergency setting.
emergency setting, exactly. So that's the gallbladder here. Basically, we can see it, head, body, and almost the neck of the gallbladder here. So on him, I'm going to move more intercostal instead of the subcostal approach. Let me show you subcostal first, and then I'm going to go intercostal because I will be using the liver as a window to guide my son. Since he's eaten and there's a lot of bowel there, I don't want to send my son here through all the gas and go to bowel much. So I get a really deep breath, hold it in, deep breath in and hold, and that's a decent gallbladder there, yes.
What's below it? What's below that?
Let me just read.
Wait, portal vein.
Okay, question? Yeah. So, yeah,
Yeah,
so
because
he
it's contracted.
it's contracted and he ate. So, gallbladder, this is all liver, no portal vein. So if I go, just breathe normal, relax. If I go intercostally, I'm able to get the whole gallbladder there. It still looks very contracted, and you can actually see the thickness there. The dark part here is the lumen, and this is just contracted gallbladder. So it extends from all the way here, going down and over here. Here you can see the porta hepatis there.
So you have stones in there, working on
Depends, most likely yes, depends on the size of the stone and how contracted the gallbladder is because of all this bowels shadowing here. This is all bowel. It's very easy to mistake bowel, to mistake it for stone, yes. So that's why
But you can
it's,
see it. Do you see it contract in the image, or it's just
Yes.
moving up?
no, it's not moving, it is, let me turn it again on. It's a little bright there because it's not projecting nicely on this window. So here, you see this double line, this line inside? That's just like, so this bright line outside is the wall, and this line inside is just a contractor. So the wall
There was
is
wall thickening, you could see that.
So we cannot say on this image, if I were to measure, where's this thing? Oh, this is beautiful now. So ideally, typically the wall would be from here to here, which is a normal thickness, but on here it appears it's going right up to there. So that's an erroneous wall measurement or falsified wall thickening because of the contracted gallbladder. So it's best not to measure the wall and call it something thick and say just patient ate an hour ago, contracted gallbladder. Please here.
My defunct almost non-diagnostic for gallbladder disease because it's contracted.
So there you see that beautiful picture wall now.
That's a good.
That's beautiful. Now that the lights are turned off, we can actually appreciate how. So this is the lumen. This is the lumen. Not on this side. We're just focusing on the fundus of the gallbladder, the body of the gallbladder, the neck. Maybe we can apply from this angle. So Hussain, take a deep breath, please. Hold it in. And there is the gallbladder neck again. Breathe, contracted. So neck here, and then for the vein, this dot is the hepatic artery, and this is the CPD begins to stretch out. This is where my cursor is. I think this beautiful CPD there, stretch it out here. So these are our and you can just see the hepatic artery cross section there, but this is the body part going on. So as we scan, we'll see the hepatic artery as it sort of traverses and crosses over. So that's the body part right there. You see it?
It's the plain one.
the hepatic artery. Hepatic artery comes off the aorta, like the cerebral cilia, and it sort of crosses like this. So on that image, it's going to go across obliquely, left to right, obliquely. Yes. So let's see if there's. Can I find the color here?
Color?
Color. Color there. Okay. And then the color box will be.
This look.
Like that. Oh, beautiful. Thank you.
Tasneem, let's start.
So then we'll start again. So that's the bile duct. Okay. You'll go. So let's. Just going to put this
Okay.
here, and we'll put some more genetics from that. Put more inside the side of the bench, the color. And put this through.
Do you want to do light?
No, the darker it is, the easier it is to see. We'll turn the color on. So hold the probe with your finger down. No, just like a grip if you're holding a pencil or something. The lower you hold the probe, the more steadier your grip will be and the better your image, and it will not hurt you. So closer to the patient. Then probe goes more vertically instead of more vertical, straight down. Really? Yes. If it comes in and out. So let's bring it up. There we go. There. Let me just squeeze it. See? Just reach over. So here's the head, body, and the tail coming in. So when I unfreeze, you'll see it move up and down. There it is, beautiful. There's, yeah, you see it? Tail, body, and then the head is obscured right now. So if you angle the probe a little bit, the tail is higher. So all the time it is quite So there's basically the from here all down and down. So Hussain, if I push your belly out. Press the belly out. Yes, reach over, freeze down. Excellent there. Okay. Okay, we can unfreeze and we can move forward to the gallbladder. It's a bit sweat. Let's start with the. You can start in the orientation. So I usually sort of kind of holding a probe like this, just to get orientation. And then you just move up on the costal because here you're hitting gaps, right? So we're going to go into the ribs there. You see a glimpse of the gallbladder right there. So now all you have to do is tweak your probe and straighten it out. So that's the transverse image. So basically go superior to inferior transversely. And if you actually press the image, no, it's on the other side. Yeah. So if the notch is reversed, you'll feel yourself move. Like if you move the probe in one direction, the image moves in the opposite direction. So that should feel you that you're in the right. So now when you turn set, there's the beautiful gallbladder.
That's, we'll,
On,
yeah, that's, we'll try to get another.
and then this is transverse gallbladder.
How do you elicit Murphy's on this? Like,
Marpies, if you're scanning the
Yeah.
patient, they will really
like
when
rinse the
if you go over the gallbladder. Now, there's some patients who have pain everywhere. It hurts, it hurts, it hurts, it hurts.
Like they say with
So-
sonographic Murphy's
Sonographic
positive, so that
It's like you're scanning and they'll
and
be
then
like,
just that
they'll
spot.
either rinse or they'll say, oh, it hurts there. So that is how you would differentiate.
Because I mean, if it's all over, it's not.
It's, yes, and if it's all over, then you sort of just say, okay, is it hurting you? Is it hurting you? Is it hurting you? You just ask at every point, and if it's positive Marquis, it will hurt more compared to
It's,
a Marquis sign is tenderness over the gallbladder. So if your gallbladder is inflamed, cholecystitis, when you press over it, the patient actually jumps with pain or hurts.
Do you go any markets?
For the gallbladder? Not really, unless it's a huge gallbladder like that. But yes, so the basic thing is you find
They
it
wouldn't
and
kill
then
that
you
pain
turn
with
your
breath.
probe depending on how it's lying. You are welcome. Yes, nice.
Physical exam would be beautiful. Okay.
Can we try the butterfly?
Yes.
That sounds amazing.
I have some.
Much lighter than the
Thank you.
You're welcome.
butterfly, much lighter.
problem is it's not gonna project, so I would rather we project and let everyone, because we're not gonna be able to see anything. So I would say we stick with this. I wanna get people hands-on. If you wanna do this, we can kind of do it separately, or the second person, because it's not gonna project.
Can I try
And we have another 20 minutes or so, so I don't want you to get hands-on. I want everyone to get 5 minutes to at least get the final.
Okay, so you're still stand up like this and the gallbladder or just either is fine. So, okay, so this probe has a notch there, which should point to the patient's right. So for transverse, it should point to this right. For sag, it should point out like that. Hold the probe from the bottom, so you can support the probe. So like wrap your fingers around the probe like this. So it's basically like a pencil or in your hand, and you can swivel the probe around instead of moving your wrist and hurting your elbow and wrist. So the lower you hold the probe, the more control you have over it, because with all the gel, everything is very slippery. And you can rest your finger on the patient's belly, hold the probe, and then apply appropriate pressure. So the lower you hold the probe, the better. Yes. So you put pancreas there, it's going on trend. So let's move. Yes, so slide your probe up higher. Good. And so we have the liver and we have the pancreas right there under it. You can see the liver. So here is the pancreas. I'm just freezing and showing you so you have an idea. This is the pancreas right there. Okay, so now the goal is to clear that image out. We know where it is, so just make it more beautiful. So press a little harder, maybe. Good. Slide your probe up higher. And then angle down, like keeping there, just angle down towards his feet. That's the angle. Just slowly, very small measurements, very small movements, very tiny movements, right there. Almost there. You can see the turn the beam here. So, right there. Okay. Right there. And then the head of the pancreas is right there coming. Okay. So for the gallbladder, you would slide intercostally. So, this measures. No, that's the thing. It's an important vein coming into the liver, and that it bifurcates. So the gallbladder is going to be more laterally intercostal, so you can maybe see it. And there it is. So there's the gallbladder, Turn sag.
This here?
We have to take sag and transverse images, but it doesn't necessarily, the probe doesn't have to be sag or transverse on the body. It has to be oriented to the gallbladder. So you can hold your probe oblique like this and still get sagittal gallbladder. Because there's the gallbladder sagittal. You see it? Almost a tapeworm looking.
Yeah.
Yes?
I see it. I see it. Yes, that.
Yeah, it's that, yes. So just lean your probe a little bit to get the whole thing there. Right there, right there. And I'm going to, you hold the probe, I'm going to freeze the image right there. Let's go back. So this is the gallbladder here, all the way around. And this is the thick wall of the gallbladder.
Who wants to go next?
Anyone?
The paper towels is just different.
Yes, the paper towel, but maybe we can get some napkins left.
You can just use its pillow if you want. Let me take a couple from there. Sorry, go ahead.
I can try. No. No, that's all right. The notch is headed. So this will be patient's head or patient's right, depending on whether you're measuring or imaging sagittal or transverse. So you would hold the probe lower, because if you hold like this, your wrist will hurt in like literally less than 2 minutes. So grip the probe lower. Yes, very good. So this is sagittal image, and you can see the pancreas, the head of the pancreas actually on that image there, right there. And so just hold the probe there. I'm going to freeze it and show you the pancreas on that image. So the pancreas is right there. That's the main portal vein, and you're catching a glimpse of the pancreas right there, sagittally. So transverse pancreas is easier to appreciate if you turn your probe transverse and face the notch to the patient's right. Good. Beautiful. So I'm going to have you, we're cutting off the tail. Move exactly. Move over a little bit. Press a little harder. You can see the tail now. And then what, beautiful, right there. I'm just going to, no, I'm scrolling back just so you can see the landmarks. So let's go again. Slide your probe up towards the xiphoid and angle slightly straight, look like that, exactly. There is, and then slightly over. And there's the point there. You see? Right. And oops, the cursor is doing its own thing. Body tail, right there. Tail goes down, that's the body of the pancreas, and that's the head that is going to be the pancreas. There's the beautiful the head will sort of extend over here and form this curve which lies in the loop of the duodenum there. Pancreas. Nope, we're going over now. So push your belly up. Beautiful. Hold it right there. Press and hold and release. That's beautiful pancreas. So there's the whole head. There's the body. There's the tail. This is the portal confluence. This is the SMA. And this is the ABC. Look very white, like how the liver looks gray on here, the more pancreas, the more it's white, or it looks more white.
Is it like your judgment call sometimes, or
Yes, because the gray is thin, thick.
do you have a measurement of the?
No, we don't have the measurement. That's like if you want to run an elastography or if I look at a scan that measures the liver fibrosis, but it's just eyeballing and comparing it to the rest of the organs, especially to the kidney, the cortex of the pancreas. And then if you want to do the gallbladder, they're good.
They use the same probes for fibrosis.
We use the same for an elastography, yes. And we're also doing, who's next? Work on the same. I've figured out how to unravel myself from this, from the quota. So I have to launch. So in addition to the nodule, there's going to be like a ridge on the probe.
So for total vision from those, if you just color Doppler,
And color Doppler, and we'll see if there is a thrombus in the portal vein, it's not going to look foreign, it's going to look grayish, we'll be able to see it, and of course the Doppler. So you're very low down, you need to move up into the gastric thyroid area, move up, almost there, you can see a glimpse of the pancreas, yeah. A little bit higher, good. And then, okay, you can see the head of the pancreas on the corner of the screen. So you need to move your probe slightly to the other side. Okay, so you might have the probe reversed. Okay, so you had it right the first time, my bad, sorry. Okay, so you saw how moving the probe in one direction moved the image in the other way, so of course that's a giveaway. So, all right, so now let's go more midline. Right there. Press, there's a it's there, so I'll explain it when you follow. So here, that's the portal confluence. And there's the splenic vein, it's going to come up like that. So the splenic vein will join the superior mesenteric vein and form the portal confluence. So on a transverse image, we will see the splenic vein. On the sagittal image, that same image is going to be the superior mesenteric vein and the portal confluence. So that was a little move like a gallbladder, go a little, there you go. Now you see if it leads in and out. So move more lateral, move more intercostal. Okay, so now we're losing that. If you have breathe symptom, so what you would need to do, just breathe normal. If you have the patient take a deep breath, you'll know that with deep inspiration, the diaphragm pushes the organs down. So move your probe down and have it ready for where the organ that you need to scan will come down. So now we send a really deep breath and hold. Deep breath in, beautiful. See, there it is, beautiful. So find it again. No, you have it, it's not going anywhere. So breathe. So hold your probe a little more as if your fingers, no, your probe, the weight of the limit, use it for breath. Then deep breath, hold it in. Okay, so now stand there. Slide down. Gallbladder doesn't want to show itself now, so let's move up here. You're sliding off. Okay, again, take a deep breath in. There you go. So stay there, don't move your probe. Stay where you see the organ. Yeah, stay there. So now we see the body and the neck of the gallbladder. We're not seeing the fundus. So you just move the probe down, just tweak it down a little bit. There it is, beautiful. Yes, just at an angle, because you're going to look at the picture and please breathe, don't turn blue. So you're going to look at the sleeve and then tweak your probe and turn it accordingly to see how it is changing the image. So if you turn the probe one way and you like, oh, it's getting shorter and going more transverse, you slowly turn it the other way to stretch it out more sagittal. And that's the left portal vein we're getting there. All right. Okay. Anyone else? Are we done?
I'm tired. Is
You're
that okay?
quiet? Yeah.
But I came in late.
No, that's okay. So there are no pores here. Thank you. So have you seen it before? Years and years ago? Okay. So transducer has a notch which shows which side is right and left. So this will be always to the patient's right if you're in transverse plane. If you're in sagittal plane, this will be towards the patient's head. Okay. So we are basically focusing on the pancreas and the gallbladder at this point. So very good. And we have the gastria with the probe there. And turn slightly. So go here. And now we have to press a little because there is always gas there. The stomach is anterior to the pancreas. So we need to try and get that out of the way. There's a beautiful pancreas there. Yes, I'm going to freeze this picture so that I can bring my cursor up here. So over here is the tail. You're catching. There's the body. Okay, now we're in the liver. No panc there, right there's the pancreas again. So I freeze it right there. Okay, body and tail right there. That's the pancreas. Sort of tweak slightly angle up because the tail is usually higher than the body. It sits obliquely there. There's a beautiful pancreas. So keep that pressure. Let me freeze this image. And here is the splenic vein coming up, right here, this darker area. This is the tail of the panc, and this is the splenic vein. It joins and becomes the portal confluence. So if I just scroll back a little, I see much nicer image there. Beautiful there. So portal confluence, head of the panc, body of the panc, tail of the panc. See? I think beautiful. Nice. That's a lovely image there. For the gallbladder, you would slide more to the right. Moving, keep moving, keep moving. Okay, you see the liver there? So let's angle. The gallbladder usually lies on the underside of the liver, so I'm imaging you can start by holding a probe this way. And there you can see it coming, let me move my cursor. So this is the gallbladder here. So what our aim, our goal is to just get a beautiful picture to make sure the wall is not thick and it's not inflamed, there are no stones in the gallbladder. So we'll have the patient taking a really deep breath, hold it in, and see the liver move down. And let's find it right there. So our patient was told that he has to eat. So his gallbladder is contracted at this point. 5 minutes here, we are almost done here. So this is the gallbladder. One does put in the gallbladder. Portal confluence here, and you can see the and then if you want to turn transverse, you turn your probe 90 degrees to how you're oriented and fully transverse. And so, tiny gallbladder there, transverse, and you do that round off. You see one of them down? So hold the probe right there. I know, freeze it. Sure. So basically, this is the gallbladder. And you see, we can barely see the lumen because it's contracted after me. This dark line is shadowing from the rib. So the rib is up top here, and it absorbs all, because the bone is dense, it will absorb all the sound waves, and you'll get a blackout behind the ribs. So the goal would be to then try and scan between ribs to get better pictures. Okay. You are welcome. Anybody else? Questions? A big thank you to our patient for letting us all press on his belly. Thank you very much, Sentai. And then I have a lot of goop here. Let me get your pillow and we'll wipe off all that too.
No problem.
Thank you.
That was cool.
Would you like to scan on somebody?
No, I don't have
No, you're okay. Okay.
Okay, so. Anyone want to volunteer?
Does anyone want to volunteer so Hussain I can try scanning?
Okay, thanks, Ali. We got a couple minutes.
So I have to take everything off?
No, just.
I knew it was risky asking.
It was a.
That's a typical question. Okay. All right, so, unless you're left, you are left-handed, would you prefer to scan with your left hand? I'm not
Oh, my
just
right
because-
hand's equally coordinated.
Okay. Most left-handed sonographers do scan with their right hand and they use their left hand to touch.
Okay. Okay.
So, ultrasound probe the notch that I was telling people about.
Can put the chart.
Thinks this is head or his right side. You put the gel first, you put your on the belly. Cool. So,
From the right upper quadrant would be up here.
so this is how it's like.
Right there.
Yeah, so we're scanning the pancreas, we're going to get a gastric here.
Okay.
So this is Sagittal image. And then you see beautiful liver with the IVC, look at that coming, so that's the left lobe of the liver and IVC. We're not interested in that, and we want to move down here, that's the head of the tank. So if you hold this pressure, I'm going to let go, press a little bit more, and I'll show